All right, we can start. People will probably trickle in because we're a little light right now. It looks like lighter than we have been. So I'm Dr. Yanichko, one of the academic hospitalists on team one right now. I think I've worked with like 4 of the interns so far, but nice to meet everybody. So we're going to be interactive today and start with a case. So you guys are going to be giving differentials for us, and we'll go through a case and try to figure out what's going on. We'll go through a differential specifically for headache emergencies, talk about the management of specific headache emergencies, and then do some final tips and takeaways. So we are in the clinic and we have a 37-year-old female who presents with the chief complaint of headache. So before we ask her questions, let's go over differentials. So what are we thinking with headache? We're gonna make a really long list. Which one? Tension headache. Migraine. Cluster headache. Preeclampsia or eclampsia. We'll do both. I don't think we only have one emergency. Stroke. All right.
Hypertensive emergency.
Hypertensive emergency. Let's talk a little bit more about stroke really quick. What is stroke in the fast of a stroke? I mean, is headache in the fast?
No.
So what kind of stroke would it be? Hemorrhagic stroke. Okay, I heard thunderclap. What's that? So they said subarachnoid. Aneurysm, which would cause, are you saying like just an aneurysm or what happened to it? Okay. What does that cause? Which type? Subarachnoid, yeah. So ruptured aneurysm.
He can have subdural, but she's just
Subdural, that's a good one. Subdural hemorrhage. Let's finish that one off. What's the other dural? Epidural. All right, so bleeds. Do you want to do the vitamin D? I don't usually do that, but if they're familiar with that, we can go through vitamin D.
Yeah, you guys remember the vitamin D mnemonic for differentials, the vasculitis, infectious, the trauma, toxins, autoimmune.
What's a vascular autoimmune cause? It's also an emergency. Giant cell arteritis. Yeah, that's the one.
The polyangiitis of CNS is also vascular.
Okay.
Meningitis.
Meningitis. That's a good one. On the infectious route, what else could it be? Which one?
Neisseria.
Okay. What other infections or encephalitis maybe? What would cause a headache? Okay. I don't think that typically causes a headache. Maybe more encephalopathy.
Sinus thrombosis.
Yeah, venous sinus thrombosis. Very good. Don't miss that one. I was thinking abscess. Actually, mass effect. More likely to cause a headache.
So, glaucoma, acute angle.
Yeah, nice. Acute angle glaucoma.
So fast process.
Elevated
Walled off lesion.
intracranial pressure from
Yeah, we used to call pseudotumor.
Yeah. Pseudotumor cerebri. Nice. Good. What's another? Yeah, thank you. CO poison. From what? From this. Every first day off, I get a headache. All right, that's pretty good.
The cerebral vasoconstriction, reversible cerebral vasoconstriction.
Yeah. Reversible cerebral vasoconstrictive syndrome, and it's its sister one, which is PRESS.
Press, but then fused at
Yeah, so PRESS and
Heat stroke.
heat stroke. We'll talk about a lot of these. Anything else you want to add, or can we talk to the patient now?
I think we should talk.
All right, let's talk to her. Yeah. She has a bigger headache since we've been talking. Oh, sorry, that was supposed to be up the whole time. One of my favorite shows. All right, so what are we asking the patient? And I have some limited information to give you, but she's got a pretty bad headache, so keep it brief. What are we asking her?
When did it start?
So it started about a week ago, but it got a lot worse suddenly today. It started in the back, radiating to the forehead.
How bad is it today?
Excruciating. Not really.
Have you experienced any of this before?
So I do have a history of migraines. I usually take something that my primary gave me that works, but it did not work.
Does it feel like a migraine?
Worse.
Can you describe the pain? What's it like?
It's excruciating. It's a terrible headache.
Is your vision affected?
It started in the back and it radiates kind of to the front, but it feels like all over.
What were you doing when you had the headache?
Nothing. Sudden onset.
Any alleviating symptoms? Does it improve? Or you laying down, standing up?
No, nothing's making it any better.
As in making
It's the worst.
No, well, not really. It's just that's as bad as it can be. Yeah, I got nauseous and threw up as well. I don't know what photophobia is though.
Any visual problems?
No visual problems, but yeah, light makes it worse. If that's what you mean.
No double vision.
Mm-mm.
Any chronic conditions?
Just migraines. Yeah, my primary told me I might have some high blood pressure and started me on a medication. I'm not sure the name of it. Told me to change my diet and exercise a little bit, but I haven't really started that yet.
Any recent infections?
Nope,
Did you have any fever?
nope.
Are you taking the medication?
No, just take what they tell me for headache. I'm not sure the name, but it only helped a little bit today.
Are you taking your blood pressure medication?
Is she on birth control?
Nope.
I know you guys are asking a lot of questions, but this patient setting is the emergency room, right?
Yeah. I did say clinic, but where the ER.
My first question is it the worst headache in your life? That is my first question. Why is it important?
Yeah, so worst headache of their life, and the speed at which it comes on is what gives it that thunderclap quality. So you want to specify with things like headache, chest pain, shortness of breath. You really want to know. Someone asked what she was doing, which is great, but you want to know the onset, like the speed of the severity of all these symptoms, because that weighs heavily one way or the other. And
So onset to the peak is few seconds or few minutes.
exactly, yeah.
Or is it the worst headache in the life? Then I start worrying more.
Yeah. So, and then she said she had a headache for a week, but it got worse suddenly. That doesn't make it less of a thunderclap. It's still, she had a dull headache, and then boom, it hit her in 30 seconds, which no one asked, but it really just came on within like 10, 15 to 30 seconds and became the worst headache of her life. So what do we want to do? So quick triage first, make sure make sure we don't need to start CPR. So a little hypertensive, 180/90. We did a quick orthostatic and it didn't change with sitting up or standing up. Pulse is good, 74, regular rhythm, no fever, and 97% on room air. Only in distress from pain. We go through our basic physical exam. The big thing is that there's a little plantar reflex upgoing on the right, but strength is equal. There's no focal deficits. And you are good enough to check for papilledema, and there wasn't any, thankfully. Everything else is within normal limits. So what are some tests you want to order for this patient? EKG.
CBC.
Okay, so labs. We're in the ER. What can we do very quickly? That's
What
arguably
priority?
CT head. What is it? CT head, yeah, top priority.
With or without contrast? You need to specify.
Without contrast first, right? So we did that first. We ordered that first, but in triage, people get things a little bit quicker. So we did get an EKG first with those vitals. That was normal. They pulled an echo really quick, because you guys are good at bedside echoes now, and you found that they have an EF of 60, about 60 to 65%. We'll get a formal one later. Looked at the carotids really quickly. There was no obvious dissection. And then you guys said CT head without contrast. Very good. Now we can send them the CT scan. We did this all within 5 minutes. So didn't mean to leave in the arrows there, but what do we see? Why do you say subarachnoid? Okay, very good. Very good. So that's the bilateral cerebral cortical sulcus and the sylvian fissure that are lighting up. So that suggests a subarachnoid hemorrhage. The sylvian fissures separate the frontal, parietal, and temporal lobes. So they're hyperdense, and that shows blood. Yeah, see them there. So then we go to a CT angiogram to look for the most likely cause, and we find a complex anterior communicating artery aneurysm. Is that a surprising place for it to be? Why not? It's the most common place for it to be. So the radiologist knew where to look. So a lot of centers, and I think ours can do the reconstruction or TRgram, very cool. And that gives us a good 3D look at it before they go in and treat it. So you see a large lobulated saccular aneurysm there in the front with the arrow. All right, so this patient was admitted to the ICU, started on or given a mannitol dose to bring down the blood pressure, as well as a labetalol drip to bring her blood pressure down under 160 systolic. That's the goal. We can talk a little bit about these meds later. Neurosurgery was consulted from the ER and took her for definitive treatment, which is coiling and clipping of the ruptured aneurysm. She got tranexamic acid, 1 gram IV over 10 minutes to prevent rebleeding. And she was started on PO nimodipine, 60 milligrams every 4 hours. How long do they have to be on nimodipine, and what is that treating? 21 days, right? And what is that preventing? Vasospasm, which can lead to the complication of ischemic stroke. Yeah.
But
Good.
the patients usually stay in neuro ICU not for 21 days.
Yeah.
And they take them off nimodipine.
If they
once
got
they step down.
right, if they're cleared by neurosurgery to come off and they've had the daily transcranial Dopplers not showing any constriction, then they can decide to stop it. Which is the case in this patient who was there for a week before she was discharged. So subarachnoid hemorrhage is what she had. It's arterial blood in the subarachnoid space after a cerebral artery aneurysm rupture. Like we talked about, the anterior communicating is going to be your most common cause. And then what condition is that associated with? A lot. That's autosomal dominant. Polycystic kidney disease. Yep, exactly. Some other risk factors, obviously smoking and high blood pressure. And then the type 4 Ehlers-Danlos, which is a procollagen mutation, is specifically associated with aneurysm ruptures, things like that. The reason it's so important to get a good history on them and find this and treat it quickly is because the mortality is so broad based on when it's caught. So you catch it early and you get in there and coil it and clip it, it's only an 8% mortality, whereas if it's missed long enough, mortality goes all the way to 2/3. So this is one of those like sepsis or STEMI where you got to catch it as quick as possible and you can really save their life. In about 1/3 of cases, the thunderclap headache has a mild headache in the days leading up to it as well. So you might not always catch it in time, but it's something to have in the back of your mind. So the reason for that week of a headache that our patient had was they were having a minor bleed from the aneurysm before it fully ruptured. And that happens in up to 40% of patients, like we're saying. So the really important info, and we'll talk about some red flags later too. You want to ask if it's a change from their prior, which I think someone asked, like it doesn't feel like your typical migraine. If they have that stiff neck, it's very important. Do they have a history of seizure? Did they pass out or have a witness seizure from somebody else? And then if they have focal neurodeficits, these of course are some of your red flag signs. The reason we get the CT head is, I think I meant to put without there. Let me change that. So that's about 100% sensitive if you get it within the first 3 days of a bleed to rule out intracerebral hemorrhage. If you miss it, if it's been more than 3 days, those RBCs can start to degrade, and it's the contrast on a non-CT is not really there. So you could miss a bleed on a non-contrast CT. If you still,
Sorry,
Yeah.
But if it's missed and you strongly suspect it, what can you do? The LP will show
Mhm.
xanthochromia, right, from the designated red ones.
Yeah, if they're giving you all the red flags and this feels like a slam dunk bleed and the CT head is negative, you don't know when the headache really started. Maybe the patient's unreliable, maybe they're alcoholic, maybe they're older and have dementia. You can get an LP, and we'll talk about what you find with an LP if the CT head is negative. So the big one's going to be the erythrocyte count greater than 10,000, and that'll probably be the buzzword on boards, or that it's what will they tell you on boards that it's yellow, like almost red to yellow.
Like this
Yeah.
xanthochromia.
I just don't know if they'll say xanthochromia on boards, just to give you that.
They describe it as xanthochromia.
Yeah, and then the difference, how do you know that it wasn't a traumatic tap if there's blood? How do you tell a traumatic LP from true blood in the CSF?
Stay same in the all bottles.
Exactly, yeah, the RBC count will go down in each tube. They're getting 4 tubes, right? So if it stays over 10,000 in all 4 tubes, it's less likely a traumatic tap. Oh yeah, and the caveat is if you get the LP too fast, you won't have xanthochromia because it can take up to 4 hours for the blood to leak its way into the CSF.
They'll say also that the CSF, they say the CSF doesn't traumatic. They'll tell you what happens to the CSF as you get subsequent tubes. So if it's traumatic, the CSF would
Get
clear,
less,
it would
yeah,
get less
color
red
will
blood cells
will
with
become
successive
yeah.
tubes. But if it's true xanthochromia, they'll say it stays the
Mhm.
same.
Which makes total sense. So the management, the ICU question will be blood pressure goal. So we want to keep the MAP under 110 until that aneurysm is secured. The systolic is usually what we use or what we tell the nurses to go off of. So less than 160 with our IV medications first, nicardipine, labetalol drip, clofepine drip, mannitol to produce an osmotic diuresis to reduce the intracranial pressure, tranexamic acid, to reduce the chance of rebleeding. And then you want to treat their symptomatic pain for their headache so they don't keep straining and causing higher intracranial pressure from the straining in Valsalva of that, and coughing as well. And then we talked about nimodipine, which reduces vasospasm, which would potentially lead to ischemia in the affected area. And actually doubles the mortality risk if you do let a patient get vasospasm. So we can talk a little bit about some of the other headache emergencies that we have up on the board. When you look at neurology books, it's more like not too important for us, but splitting them into primary, secondary. Primary is going to be your like migraine, tension headache, cluster headaches, those. And then secondary are the headaches due to something else. So that can kind of be your easy way to remember. It's something else that's causing the headache. And then the trigeminal neuralgia, and those get their own category, painful cranial neuralgias. So all our secondary headaches, I think we got most everything. We didn't say trauma, but that's a given. We've got epidural, subdural hematoma, hemorrhagic stroke, venous sinus thrombosis. I think we said dissection, right? Didn't write it up there, but someone said dissection. Tumor, pseudotumor, withdrawal. Yeah, we got it all. So the second most common cause, and it's interesting that's the second most common cause because it's very rare that you see this diagnosed in the hospital, even though it's probably happening more than we think. And we think we have a patient right now, right? So we're waiting on the MRI to confirm. But the reversible cerebral vasoconstriction syndrome is going to be your second most common cause of a thunderclap headache. So say you've ruled out subarachnoid, you can get an MRI and see this, does this one? Yeah. See the specific edema in the posterior. There, yep. So a lot of triggers, just exertion, Valsalva maneuvers, the antidepressants, specifically the MAOIs, and then even interestingly, triptans can cause it. Pregnancy, a lot of people will come in, pregnancy induces it. I think that's more specifically if you develop preeclampsia or eclampsia is why pregnancy is a cause. And you're going to treat them with verapamil or nimodipine and get a repeat MRI 3 months later to follow up and make sure it's getting better. Stress is kind of the sister condition. It's more related to hypertension. It's kind of what you're going to think about. And so that's going to be associated with your eclampsia patients or your hypertensive emergencies, but it should have the same findings of the edema in the posterior lobes on MRI. Dural venous sinus thrombosis, another very important one, because it needs neurosurgery and sometimes transfer depending on how severe it is. That's an extension of infection from the sinuses into the intracerebral space. These patients are going to have the buzzword of pulsatile tinnitus, although that can happen with a lot of conditions. It's something you want to have in the back of your mind. And then they get the cranial nerve 6 palsy because of increased intracranial pressure. And you could see papilledema as well. So they're not able to AB duct. And this is obviously IV antibiotics and surgical drainage, which if our surgeons can't do here, might need transfer to TGH or something. But I have not had a case here. I've only ever seen it at TGH, so I'm not sure if our surgeons are capable. I'll have to find out. Another very important one, internal carotid artery dissection. You guys know a lot of the causes of this could be from trauma, especially from your classic chiropractor neck manipulation. Could be from high blood pressure or a connective tissue disorder like Ehlers-Danlos at type 4. They're going to have orbital pain possibly, and then the boards will be a Horner syndrome. So on the right side there, he has the droopy eyelid and the constricted pupil. And their focal deficit will be on the same side as the Horner syndrome. So that's kind of going to be your vignette. You're going to want to get a CT angiogram or MR angiogram to confirm that one. Is a carotid ultrasound enough to diagnose this? Why not? Yeah, exactly. You need the intracranial vessels as well. Research is still kind of not showing any difference between just using aspirin alone or full anticoagulation. So it's sort of neurology dependent on which one they prefer. I typically see aspirin used more often, but you do want to prevent stroke because the dissection flap can cause obstruction and ischemic stroke and things like that. So you're definitely going to want to have neurology on board for any further recommendations. This is my least favorite mnemonic ever because I think it's not a good one, but Snoopy's fun. So this is going to be your red flag headache symptoms. So if it's like systemic things, it's more of a red flag with their headache. If they have a history of cancer, if there's a focal neurodeficit, if it's sudden onset, which is your thunderclap, age older than 50 is always going to be a red flag for headache. Or if it's a first time having a headache after age 50. If they passed out, so had syncope, if it's a change from their prior headache, if they have signs of increased intracerebral pressure like papilledema, pregnancy, of course, if it's after trauma, or if they have immunosuppression, those are going to be kind of your red flags for headache and warrant more investigation. Yeah.
That's a quick comment.
Yeah.
The cancers that love to bleed and cause hemorrhage when they go to the brain, which ones? There's just a few of them. They love to bleed when they go to the brain. I'll tell you one, melanoma.
I don't know, Ms. Hoffman.
Renal cell, choriocarcinoma, melanoma, and lung adeno. So, or any adeno. So if the patient has those kinds of cancers and they have a headache, you're suspicious for hemorrhage. should be high and get a non-contrast CT.
Absolutely.
Is it because they have those angiogenic growth factors?
Yeah, yeah.
VEGF.
Pathophysiology comments.
Mhm.
That will help me remembering things.
Yeah. So you guys are already smart enough to know we get it without contrast, the CT head. But there are some times where you might want to get it with contrast. When do you add? We'll talk about first, like what do you get when you add contrast? What might you see that you wouldn't see? And then why would you what type of patient would you want to get it with contrast, I think? There's not really many wrong answers, just here and so. Yeah, sure.
If you're suspecting infections, possible abscess.
Yep. So abscesses probably wouldn't light up unless it was really severe ring enhancing. You're going to need contrast. So if you're suspecting infection, tumors are tumors are better seen with contrast. Anything else?
MS also they want with and without MS.
Okay, if you know they have MS and
Or
thinking
you're
like a
just
flare.
looking for MS, yeah.
Yeah. You're gonna get the MRI
Yeah.
with, yep. So this is gonna be like, you can narrow down your red flag to these. The age greater than 50, history of cancer, and immunosuppression. Those are kind of gonna be your big three where you're gonna want to get contrast too. And you can do with and without. You can order an MRI with and without contrast, and you'll have both if you really want to get both. But after getting that initial CT head without contrast, like say a stroke alert or something, you also want to get it with contrast if they have these things. So now we talked about LP, but you want to make sure you get the opening pressure. That's a separate order. I don't think the radiologists automatically do an opening pressure unless you ask for it. So you can put either nurse communication or put it in your free text when you order your LP, or call IR, however you want to do it. And then if both of those are negative and we're still having this severe headache with the red flag symptoms, now you can move on to your angiogram. So CT angiogram, MR angiogram. The neurologists here a lot will just go ahead and get it. I think our stroke alert last night, they went ahead and just went straight to CT angio and added that in. So you do see LP skipped a lot here. If you're still stumped, or it's more of like an ocular headache, it's more of an eye pain, then you want to get ophthalmology, roll out the GCA, roll out other eye pathology. They can do a full, retinal exam. And then if you've done all of that and still nothing identifies a cause of the headache, then first of all, you have neurology on board, so you're talking to them. You have an expert second opinion, and you can MRI the rest of the spine to see if there's any pathology in the spine that's referring up to the head to cause the headache. So let's do a couple questions. I think I just have two. Anyone want to read this one? First year. All right, go ahead.
4-year-old female presents to ED for severe unpulsified bilateral occipital headache with photophobia and vomiting that began suddenly 3 hours ago while doing TikTok dancing. That's read by alcohol. An exam blood pressure was 144 over 924, pulse 89, saturating 100 room air equilibrium. She appears uncomfortable and prefers a dark room. Neurology exam negative for a focal deficit or other symptoms normal. CBC and CNP as well as pregnancy test are unremarkable. Which of the following is the most appropriate extent? Brain MRI, B CT, C lumbar puncture, D conservative trial of symmetric plan.
So your first year in the clinic, what's your plan for this patient? What do you want to do first? Head CT? Okay. Clinic attendings, you would be okay with that? So what is making you order a head CT in this patient? Why are you not thinking it's just a migraine and you're being conservative? Right. She's over 50. This is the first time that she's had this headache, and she automatically has the red flag of over 50. So while this could be a migraine, you do need to rule out something more sinister. So I had CT in this one. The problem with doing the sumatriptan in the red flag symptom patients is sumatriptan is actually shown to reduce the pain from a subarachnoid hemorrhage. So you could be masking the true problem and missing an emergency. All right, let's do one more question. Actually, it's kind of a two-parter. Anyone want to read this one? Go ahead. Team one.
48-year-old woman was seen in ED in Florida complaining of a right-sided headache with neck pain for 3 days. Her past medical history was unremarkable except for occasional headaches associated with her menstrual period. She was visiting an amusement park with her teenager sons, and she attributed her persistent headache a long day at the park in the heat. Happened to me over the weekend. She did not seek medical
Uh-oh.
attention until she experienced a 10-minute episode during which she had confusion about how to get from Morocco to Norway in Epcot. Accompanied some left-hand clumsiness and numbness. On examination, she had a mild right ptosis with a smaller pupil on that side and the left upper extremity dripped. So what do you think is the most likely cause of a headache? Option A, cluster headaches, B, right vertebral artery dissection, right internal carotid artery dissection, right external carotid artery dissection, or it's more hemicrania.
See? Okay. Why that one? What specifically? Tells you it's internal carotid. Because it's causing the Horner syndrome. It's all right. And then follow-up question. Interestingly, she gets an MRI and she has a right middle artery territory infarct. What do we need to do next? Need to get a CT, MRA, ultrasound, echo, TTE or TEE. Because the CT didn't specifically say angio. So that's why that one's wrong. You could do a CT angio instead if it's faster. And you don't do carotid because that could miss the distal ultrasound because that could miss the distal carotid lesion, like we talked about. Good, good. So the most important things, the ones to know for boards and whatnot. Subarachnoid hemorrhage, keep the blood pressure under 160 systolic, a neurosurgery evaluation for the aneurysm coiling and clipping, at least to evaluate if it's appropriate. You want to reduce the intracranial pressure with those medications that we talked about. And then nimodipine, the buzzword is 21 days to prevent vasospasm or until cleared by neurosurgery. The big three red flag symptoms, age greater than 50, history of those neoplasms or immunosuppression, to jump to CT with contrast to rule out anything going on there. And then to do an LP if you're highly suspicious, even after a negative CT, because there's still about smaller than 5% chance that the patient will still have something that you missed on the CT. And then lumbar puncture and ophthalmology, neurology referral if those initial brain tests don't show a cause. Good. Any other questions?
Do we have neurointerventional radiologists
Oh yeah.
that do the coiling?
Yes, they do. Yeah, they'll take for thrombectomy, for stroke. So we have a pretty good stroke center here. Yeah.
It's like allergy and timing. Can you expand on when we would want MRA or?
Yeah, that's a neuro board level question. But if you're getting an MRI already, you can do that. Plus, MRI is just going to have a little better soft tissue. So I prefer MRA myself. But if you just want a quick thing and they don't have a contrast allergy, CT angio, yeah. I need to ask our radiology department, but I don't know what contrast they use in MRAs. And remember, you can get issues with MRI contrast if you have like end stage renal disease and whatnot. So the skin, what's that called? The skin condition. Yes.
Nephrogenic.
Systemic fibrosis. Yeah. So those are basically use the clinical picture to tell you which contrast you want to give to the patient and how fast you need it.
not sure, but
Mhm.
the MRI should give you like a better image of the posterior
Mhm.
circulation, I think. Like if you suspect pica from or posterior cerebellar artery dissection or aneurysm or so on.
Yeah.
So
I don't know.
intuitively it's.
Yeah, I don't know that CTA would be worse, but I know for the soft tissue, the MRI is good. Plus, we have all the different types of MRA here, the digital subtraction, angiography, and all that stuff. They can do a 3D reconstruction.
They do the 3D reconstruction.
Yeah, so our MRIs are really, really good for neurology here. That's good. Anything else? Neurology is probably the best on boards. It's really just black and white, cut and dry. Those should be the easiest questions. So get all the neurology questions right. All right, thank you.